Bismillah ar-Rahman ar-Rahim. Our topic today on the endometrial lesions. Uh, we have some cases at first. Our first case, she was a female patient, 64 years, coming with postmenopausal bleeding. And that was her MRI. This is the sagittal, and this is the coronal view. This is the sagittal again. This is axial T1. There is no significant thing in it. And this image shows the post-contrast. This is enhancement of the myometrium, and this is the endometrial lesion, which is not enhancing except in the delayed image. So in case like that, how to report? We have here the uterus is retroverted, retroflexed. We have endometrial thickness not so much thickened for her age. It's only 6 millimeter, but it shows altered signal. It is hypo-intense rather than the hyper-intense endometrium we used to see. And there is few cystic changes seen here. So we have endometrial thickness 6 millimeter, but there is altered signal with cystic changes seen inside, and the patient has complained she has bleeding. We have also thickened junctional zone with multiple subendometrial cysts, which is characteristic for adenomyosis. So we have here two pathologies, but what we have to recommend is the endometrium, the altered endometrium, because this is the postmenopausal ovary, and this is also the subendometrial cysts, and this is the endometrium. So we have to report that we have altered signal endometrium, although it is not so much thickened, for histopathology. This patient must do DNC. And we have associated adenomyosis. So if we have altered signal endometrium in the MRI related to patient age, we have to do DNC. This is another lady, I think she's 60 also, and she has markedly thickened endometrium, 26 millimeter, but with preserved junctional zone. Here, when you see the junctional zone, you must see in multiple planes. You see here in this plane, and also in that plane, it's regular. There is no any infiltration, but the endometrium also show altered signal. So this is thickened endometrium for age, again for DNC, for histopathology. Because in the early stage of endometrial carcinoma, we cannot differentiate endometrial carcinoma from hyperplasia. So we have to do histopathology. Then we came, before we go to other cases, what are the causes of endometrial thickening? We have another lecture on the channel on the endometrial thickening, but here more cases are demonstrated. The causes of endometrial thickening in the childbearing age may be polyp, hyperplasia, tamoxifen intake. The most important are the pregnancy-related disorders, incomplete abortion, gestational trophoblastic disease, ectopic pregnancy with increased thickness of the endometrium. Those must be taken into consideration in this age group. And then we have endometrial cancer, but it's very rare in this age group. But it can occur. If you found atypical features, you suggest endometrial cancer. In the post or the perimenopausal age group, we have endometrial cancer, endometrial hyperplasia, endometrial polyps, and exogenous estrogen like tamoxifen intake also. Endometrial cancer is the most grave, but it is not the common cause of postmenopausal or perimenopausal bleeding. This female, 50 years old with perimenopausal bleeding, we have here thickened endometrium, 23 millimeter, but the advice don't depend on the transabdominal ultrasound. Here the uterus is rather bulky and we have thickened endometrium, but please, you must do transvaginal with colored Doppler in all perimenopausal and postmenopausal age group. This is the transvaginal examination showing the markedly thickened endometrium. Note the thickness even differs from the transabdominal to the transvaginal, and we have rather preserved junctional zone or subendometrial halo. The endometrium is rather heterogeneously hyperechoic, so it must be biopsied. And also, when you put Doppler, there is increased vascularity, especially when we found the increased vascularity in one focal area. It's more with growth. If you found the vascularity all through around spiral arteries, then we are talking maybe of hyperplasia. So in this case, we suggest endometrial malignancy. It was grade 1 endometrial carcinoma. Another case, by transvaginal ultrasound, the uterus is retroverted. There is thickened endometrium, 13 millimeter. In this age, it's thickened with cystic changes, but also there is reserved subendometrial halo. You must put Doppler. There is vascularity here, so better for DNC. In a thickened endometrium for age, don't write frankly it's malignancy. You are not sure that it may be malignant, so we said malignancy could not be excluded. Thick endometrium for age for DNC. So we must take care that all cases of postmenopausal or perimenopausal bleeding, please put Doppler on the field of view. If you found increased vascularity, especially when this vascularity is not maintaining benign nature, then you suggest it is malignant lesion for DNC. Sometimes the endometrial carcinoma can be seen on ultrasound as a cauliflower mass like that, and there is endometrial fluid entrapped inside, making like sonohysterography. So we can see this polypoidal fungating mass. So the endometrial carcinoma may present as thickened endometrium or may be presenting as fungating cauliflower mass. Endometrial carcinoma is the most common gynecological malignancy in many countries, with reported incidence of 10% in postmenopausal patients presenting with uterine bleeding. Fortunately, that the patient present early because it is usually presenting with bleeding. Endometrial carcinoma, the postmenopausal endometrium, how we consider it thickened and when to consider it normal. The postmenopausal endometrium usually atrophies. Usually it becomes less than 3 millimeter and double layer thickness more than 5 millimeter is abnormal. But you can give a range according to the age of menopause. When the patient is only 5 years after menopause, not like a patient 20 years after menopause. So the thickness differs according to age. A thickness of 7 millimeter is accepted in women under hormonal therapy. And usually I used to say that the hormonal therapy is not only the exogenous estrogen, but also the endogenous estrogen in obese patients. Take care. There may be thickened endometrium. Or patients, for example, with liver disease and unopposed estrogen also may manifest with thickened endometrium. Grade 1 carcinoma will present as widening of the endometrial stripe on ultrasound. So, again, we cannot differentiate between early endometrial carcinoma or hyperplasia with atypia or atypical or only cystic endometrial hyperplasia. So what to do in this age group? What to recommend in the peri and postmenopausal age if we have asymptomatic woman with junctional zone preserved and no vascularity on color Doppler, then we can follow by ultrasound just. Don't do invasive procedure. But if it is vascular on color Doppler, or if the patient has bleeding or has any abnormality, symptomatic, the patient is symptomatic, then better to go directly to DNC. What are the ultrasound characteristics of endometrial cancer as defined by the International Endometrial Tumor Analysis, IETA? We have many characteristics in this paper showing how to measure the endometrial thickness. Either you can measure the thickness of the endometrium if it is diffusely thickened, like this case. If it is diffusely thickened, you can say that the endometrium is markedly thickened, reaching to the internal os, with the maximum thickness, as we used to measure in the sagittal plane in the most convex part, is the most thickened part. Or you can measure it as a mass, that we have a mass measuring about مثلا 3 millimeter, 1.5 centimeter, and so on. This is how to measure the mass in the 3 dimensions. You can even get the volume of the lesion. Then you have to describe the appearance of the endometrium. If it is smooth like that or undulated like that, this is a smooth endometrium. This is a smooth endometrium, sometimes with in this indistinct interface in between the 2 endometrial layers, and sometimes the interface is distinct like this. Also, sometimes the junctional zone could not be assessed and we could not see the definition of the endometrium. The internal echogenicity of the endometrium you have to report on. We have cystic changes within the endometrium, regular cystic areas, or we may have polypoidal thickening of the endometrium, like in this case. And sometimes in cases of infertility, we mentioned that we have polypoidal thickening of the endometrium, and this have an impact on those who are going to do IVF, for example. We have also to comment on the interface between the endometrial layers. This is a smooth interface, linear interface. It may be a non-linear undulated interface between the 2 layers, or it may be an irregular interface, and this is with growth or with malignant lesion, or it may be with synechia or intrauterine abnormality. Or it may be ill-defined. I could not see it at all. Ill-defined interface between the 2 endometrial layers. We have also to comment, which is the most important of what we have mentioned before, is the endometrial myometrial junction. The endometrial myometrial junction may be regular and uniform, and this is very important to exclude invasion, for example, by malignant lesion or in cases of adenomyosis. Or it may be irregular like this one. This is an irregular. Sometimes when I describe, I can say that it is interrupted or indistinct. This is an interrupted endometrium. This is the junctional zone, and here the junctional zone is interrupted posteriorly. But take care, sometimes when the endometrium is thick, according to the physics of ultrasound, there may be posterior enhancement, and this posterior enhancement will make you could not comment on the myometrial endometrial interface, and you have to do MRI for better characterization and staging of the lesion. Sometimes you can see indentation on the endometrium by this fibroid indenting the junction, and we can use it to differentiate between polyp and submucous fibroid. In the submucous fibroid, the junctional zone is pushed with the fibroid anteriorly, while with the polyp it's not. So It is one of the points that we can differentiate between fibroid, submucous fibroid, and polyp. Then we came to the Doppler findings. The Doppler findings is very important, and many papers nowadays, they take it into consideration to predict the grading of this endometrial mass. We have the endometrial carcinoma. We classify the endometrial carcinoma into two main categories: endometrioid, which is the most common, and others, which are rarer than the endometrioid carcinoma. The endometrioid tumors, this is different stages of endometrioid tumors. When it is of low grade, it has less vascularity. We're performing the normal, the benign characteristics of the vessels, that there is good arborization of the vessels. But when it becomes more aggressive, you will see large central vessels, the malignant nature, large central vessels, lack of arborization, and very marked increased vascularity, as we see in this last case, which is grade 3 vascularity. Of course, when you use the Doppler, use the power Doppler is better in order to assess the fine vessels seen within. Another picture showing the non-endometrioid carcinoma, the carcinosarcoma, the clear cell carcinoma, the serous carcinoma, all of them show marked increased vascularity like that. And heterogeneous endometrium, not like the endometrioid type. Ultrasound predicting, so we can say that ultrasound can predict the pathology. In endometrioid tumors, a clear difference was found in morphological features between well, moderately, and poorly differentiated tumors with increasing grade and stage. Tumors were larger, had high color score, and were less likely to have regular endometrial myometrial junction and uniform echogenicity. Non-endometrioid tumors were in general larger than the endometrioid, larger in size, heterogeneous in appearance, and show marked vascularity like similar to that of grade 3 endometrioid tumors. Like this one, this case show a large mass, heterogeneous, infiltrating the myometrium. And when you put color Doppler, you found the grade 3 vascularity, which is very large central vessels and venous lakes inside, which suggest of high grade tumor of the endometrium. The 3D in the endometrial lesions had a benefit. It can highlight the invasion of the junctional zone, as we see here. This right side show marked thinning of the myometrium. More than 50% of the myometrium is infiltrated, so this is stage 1B. It is infiltrating the myometrium. Apart, we must see the lymph nodes and so on, but regarding the local invasion of the uterus, we have here, it is stage 1B. But it is not reaching the cirrhosis. So it is high-grade endometrial tumor with myometrial invasion. Another option to do to highlight the appearance of the junctional zone is the the TUI, or the tomographic ultrasound imaging. You can see here that the junctional zone posteriorly is ill-defined. The tomographic cuts highlight the invasion of the myometrium. And at the site of invasion, we have abnormal vascularity here. Note here the junctional zone. Then in this area, it is interrupted and infiltrating the myometrium. And again, by 4D ultrasound, you can see the invasion of the myometrium better than the 2D. Then we have this tricky case. Is it endometrial carcinoma or not? We have thickened endometrium. This patient was 50 years old and coming with bleeding. The endometrium is 20 millimeter in thickness with marked indistinction of the junctional zone. I couldn't see it. There is indistinction of the junctional zone. The endometrium is irregular. The interface is obscured. So I suggest it is endometrial carcinoma infiltrating the myometrium, but on histopathology it was adenomyosis. So take care, the adenomyosis with the endometrial carcinoma is so tricky. So you can, if you suspect, you can put a possibility, and you recommend to do MRI. Then we have to comment on the staging. Of course, the staging is better with MRI, but with ultrasound, you have to try to stage as you can. Even in the uterus itself, regarding the uterus itself. You have in your report, you must put the clinical information, and you have, if the pathology was taken, you have to put the histological type and grade, and then you can get the myometrial invasion. 1A is less than 50% of the myometrial thickness, 1B more than 50% of the myometrial thickness, اللي هو depth of myometrial invasion. Sometimes we could not say, is it more than half or less than half, so better to put it on the high grade. Stage 2, cervical stromal invasion. And I stress here on the cervical stromal invasion because sometimes the tumor is protruding into the cervical canal but without stromal invasion, so this is still stage 1. Cervical stromal invasion, it is stage 2. Stage 3A and B. A, if there is serosal invasion, and we have a case that there is serosal invasion and infiltrating the bowel, for example. Serosal invasion. And 3B, if we have vaginal or parametrial invasion. If the tumor extends to the cervical stroma and extends also to the parametrium, then it is a stage 3B. 4A, if it is infiltrating bladder or rectum or bowel, so take care to see all the constituents in the vicinity of the tumor. الأدنكسة MRI FIGO classification هتبقى 3A if it is infiltrating the adnexal region or there is a metastatic lesion to the ovaries or to the fallopian tubes. Then we have stage 3 and stage 4B, 3C regarding the lymph nodes. So you have to see the lymph nodes. If we have pelvic lymph node involvement, what are the lymph nodes? It is the first station of the endometrial carcinoma. It is the internal iliac lymph nodes and the obturator, and then the external iliac and common iliac, and then to go to the para-aortic lymph nodes. And if it reaches the para-aortic, then it is 3C2. Stage 4, if we have 4B, then it is distant metastasis, including the peritoneal implants. So peritoneal implants in cases of endometrial carcinoma, it is stage 4B. Not in the ovarian, it differs. In the ovarian, peritoneal implants, we see it is pelvic or extrapelvic. But here, if there is peritoneal implants, then we are talking about stage 4B. Visceral organ metastasis, lymph node metastasis beyond the pelvis and para-aortic region. So this is the classification, the FIGO classification that allow. We have new FIGO classification in 2023, but it is mainly more details regarding the histological subtypes. So if you can stick to this one, it will be well and good. If you have to see what about the pathology and the micrometastasis, then we will go to this group. But this one is fine. We have to apply what we have just said. Female patient 65 years with postmenopausal bleeding. What we have seen here, this is is not normal endometrium, not markedly thickened, but look here, this is the polypoidal increased thickness of the endometrium with breaching of the junctional zone. The junctional zone here is not good, it is breached, but not infiltrating the myometrium. Here also we can see this lesion in the coronal. The polypoidal thickening of the endometrium is seen here well also in the coronal view. There is no myometrial invasion. And here is the axial. Also, this is the polypoidal thickening of the endometrium. There is no lymph nodes. One in the lecture told me how to look for the lymph nodes. You have trace the vascularity, the vessels. Here are the obturator group of lymph nodes, the internal iliac group of lymph nodes, and then the external and common iliac. So you follow the vessels. Follow the vessels in order to see that there is lymph node or not. Here is the T1. In the T1 also you can trace the lymph node appearance. And this is the diffusion. The diffusion can highlight if there is invasion of the myometrium or not. Here there is no invasion of the myometrium. Endometrium, unfortunately, the endometrium is restricted حتى even when it is not infiltrated. So this is stage 1A, endometrial carcinoma. This is another case. Here there is a larger mass. Here you can describe either it is endometrial mass. You can describe it as endometrial mass, not thickened endometrium. We have here an endometrial mass implicating the anterior wall of the uterus with more than 50% invasion of the myometrium and indenting the rest of the endometrial cavity. So here this is an endometrial mass. Here the stair في T2 can highlight the mass well. Here. So there is more than 50% invasion of the anterior wall of the uterus. So this is stage 1B. This is the axial. Here also you can see the mass. So here this is stage 1B. Postmenopausal bleeding. This case has postmenopausal bleeding. While there is markedly enlarged uterus, the endometrium is enlarged, heterogeneous, or markedly thickened, heterogeneous. The junctional zone is ill-defined in parts, but there is no infiltration to the myometrium. But what we can see, there is infiltration of other structures. Here, there is no local invasion of the myometrium, but we have many other findings. In this case, you have to see what are the lymph node stations. Here we can see the lymph node stations. Look here, the enlarged lymph nodes, internal iliac, obturator, common iliac, and I think above can be para-aortic. This is the coronal view. Here is the endometrial mass. In this part, there is breaching of the junctional zone here. So when you try to see the junctional zones, see it in the multiple planes. So this is breaching of the junctional zone. This is the ovary, right? And then we have here right tubo-ovarian complex, tubal in part. This is a tubal structure, it is the fallopian tube, showing multiple mural nodules all through. So here there is adnexal infiltration, 3A, but we have also multiple lymph nodes reaching to the para-aortic area. So we have, it is 3C2. Then try to search. There is invasion of the bladder or rectum. Better to search in the sagittal plane. Here. There is good plane with the urinary bladder and the rectum. So there is no infiltration. But we have, so this is stage 3C2. Okay. So we have here adnexal and endometrial. When we find double pathology like that, you have 4 differential diagnoses. Either we have synchronous endometrial and ovarian cancer, and this is reported in 5 to 10% of cases of endometrial or ovarian cancer. Gynecological cancer show a predilection for loco-regional metastasis. What is meant by that? That the endometrial and cervical carcinoma can spread to the ovarian and fallopian tube. Synchronous endometrioid, endometrial and ovarian cancer at the same time. An enlarged uterus or thickened endometrium may also predict estrogen-secreting ovarian tumors in the premenarchal girls or in the postmenopausal women. And we have the most common to do this is the fibrothecoma and the granulosa cell tumor, which are estrogen-producing tumors. Another case, postmenopausal female, 83 years old. Wow, again. We have markedly thickened endometrium infiltrating the junctional zone. And here we have peritoneal implants. We say if there is peritoneal implants, then we are talking of stage 4A. 4B, sorry. So here we have even implant in the falciform ligament of the liver. Note here, there is implant in the falciform ligament of the liver. It is not a focal hepatic lesion, but it is in a falciform ligament of the liver. We have implant in the Douglas pouch here. And we have omental cake spreading through the hernial sac. It was a miserable lady. We have lymph nodes, inguinal also. And here in the coronal, you can see the peritoneal sheets of malignant spread. This is a peritoneal sheet. Here, this is a peritoneal sheet. Here also in the stair, you can see the multiple inguinal nodes and the peritoneal deposits. So this is stage 4B. That was the report. We have also a malignant ovarian lesion. I think it's seen here. Same as the other case. Complex cystic and solid ovarian mass here. Krukenberg. This is Krukenberg. Another case, 58 years postmenopausal bleeding. Again, endometrial mass. Note the soft tissue component seen not like the normal endometrium. This is the soft tissue, not normal endometrium. Of course, it is infiltrating the anterior wall of the myometrium. And here we have fibroids. And we have also ill-defined lesion here anteriorly, focal adenomyosis. So we have here many findings, uterine findings. We have endometrial mass infiltrating the anterior myometrium. We have ill-defined focal myometrial mass here. It's focal adenomyosis. and we have multiple fibroids. The junctional zone is thickened here. This is endometrial cancer 1B, and we have thickened junctional zone 16 millimeter. We have anterior يعني low cervicocorporeal adenomyosis, and we have multiple fibroids. Female patient 24 years old, coming with irregular bleeding. And this is another category, not the peri and postmenopausal. This patient has a polypoidal lesion inside the uterus, here, coming from the posterior wall. This lesion here, you must give contrast in these cases. There is enhancement.